Welcome to AETCM, the Emergency Medicine channel. Present in the case of a 60-year-old male patient from Ernakulam who was an auto rickshaw driver by profession. He was a known case of type 2 diabetes mellitus. He had come with a complaint of sudden unresponsiveness followed by decreased response since 1.5 hours back. Patient was apparently normal 1.5 hours back, after which he was brought to the ER when he fell unconscious. During the episode, he was lifting heavy objects and talking normally to his colleagues. After the episode, the bystanders noticed that although he was opening eyes, he was not responding verbally and not obeying commands. He was moving his right hand only, and he was not moving his right hand, but he was moving both his lower limbs. There was no previous history of fever, headache, blurring of visions, seizures or chest pain. Past history, only type 2 diabetes mellitus was present. Patient was a smoker with a Pacquiao index of 30, and he was an alcoholic with daily alcohol consumption. On examination, the patient was conscious, but he was restless. Pulse rate was 59 per minute, which was feeble and regular. BP was 90/50 in the left upper arm. Saturation was 98% at room air.
Why you have taken BP only in the left hand? Is it advisable or not? For a postgraduate taking BP only on one side, who is having weakness on one side, is it advisable? It is not advisable. Ideally you have to take both the hands, because this can be sometimes suddenly lifting patient developed weakness of one side. It can be an aortitis or aortic aneurysm rupture. Anything is possible. So it is better to check the BP on both sides. Since we have monitors here, we can connect to both hands and see the BP, or you can see a handheld Doppler and see what is the flow in that hand.
On examination,
what is the first investigation you do with this type of patients? First investigation before examining the patient, you have to do it in ER. What is that investigation? Any patient come to ER with unconsciousness. What is the first investigation? Blood sugar. Blood sugar is the most important thing, because he's already a diabetic. Okay, he can have hypoglycemia or hyperglycemia. Both can have different types of stroke mimicking symptoms. So you are supposed to do one sugar first itself.
So GRB was 350.
Okay, so it is high. Okay, do you think that high blood sugar can produce some of these problems?
Cancer.
Huh? How high blood sugar produces stroke?
Patient
Okay, one high blood sugar can produce hyperviscosity and produce stroke, or stroke itself can produce hyperglycemia and decay, something like that. Okay.
Examination, sir. On examination, on general examination, there was deviation of angle of mouth to the right. Aberrations were present over both hand knuckles. There was no other head-to-toe examination findings. On systemic examination, higher mental functions, his sensorium was E3, V1, M6. Under cranial nerves, pupils are bilaterally reactive to light.
9, total 9.
Yes.
Okay. If it is less than 7, what is the immediate response in ER?
Intubation.
Intubation. Will you intubate this type of patients? You intubate or not? Yes or no? So ideally, if it is very low, other than hypoglycemia or seizure episodes, you have to intubate the patient. But here it is 9. Okay. I just asked. Okay.
Pupils were bilaterally reactive to light, both eyes 2 mm. There was no ptosis, no nystagmus. There was drooping of angle of mouth over the right side with obliteration of nasolabial fold on the right side. On motor examination, the tone of both right and left side upper and lower limbs were normal. Power over the right side upper limb was 0/5.
How do you check the power when this patient is unconscious?
So he was not moving his hand at all. So patient was conscious, but
he was not able to talk to you.
Yes.
Okay.
The left side upper limb and both the lower limbs had 4/5 power because he was moving it spontaneously.
Okay.
Reflexes over the right side, biceps, triceps, and knee jerk were brisk with an extensor plantar response. Left side reflexes were 1 plus with flexor plantar response.
So one side is having
Brisk reflexes.
disc reflexes with the
Extensor plantar
Babinski
response.
sign.
Babinski sign positive.
Okay, can you tell me something about Babinski sign? Since you are a medicine PG, I am asking this. Emergency medicine, it is not required at all. Can you tell me something about Babinski sign?
Babinski sign is usually positive when there is the dermatome affected is L5S1.
Okay.
Usually there is positive means there is fanning of the toes with dorsiflexion of the great toe
Only great toe.
and fanning of the other toes.
What are the other components of Babinski sign?
There is
What happened to ankle joint? What happened to knee joint? What happened to hip joint? What happened to abdominal muscles? There is a complete reflex. It's otherwise called as universal flexion response. Okay. So Babinski sign positive means all muscles in the lower limb will be contracting. Okay. So you get contraction like ankle joint will be
dorsiflexion.
knee joint will be flexed.
Flexion.
Hip joint will be
flexion.
flexed. Okay. All joint will be flexed. This occurs due to what? What is the reason for this? When you are stroking on the lower limb for a normal person, why he is not developing this? Who blocks this? Who blocks this? This is a spontaneous response. You touch the fire, you immediately withdraw it. No? That is your spontaneous response. But when you are stroking, what is happening is you know that somebody is stroking. You try to prevent that flexion of your all the joints. That is done by which part of the CNS?
Spinal.
It is controlled by your pyramidal tract. So pyramidal tract gives an information that no need to flex like that, no need to withdraw. When the pyramidal tract is absent, your limb will have an automatism and it will withdraw, try to withdraw. So that's actually a withdrawal from that stroking. Okay, so that's a sign of pyramidal tract dysfunction. Okay, so continue.
There was no neck stiffness or rigidity. Skull and spine was normal with no external injuries. Cerebellar signs like nystagmus was not present, no tremors also. Examination of other systems. CVS was normal, S1, S2 was heard, there was no murmurs associated. Respiratory system was, air entry was bilaterally equal with no added sounds, and abdomen was soft and non-tender.
Okay.
So, diagnosis. Sudden onset right-sided upper limb monoplegia with right human facial palsy and probable Broca's aphasia due to a lesion involving the left side MCA territory.
Your diagnosis is not perfect. You are telling monoplegia, but you are told already that there is extensor plantar.
Yes.
So it is not monoplegia. Facial nerve problem is there. One hand weakness is there. Where reflexes in the lower limb is one side exaggerated. Plantar is extensor. Correct, no? Yes. So it is not monoplegia. Monoplegia means you are fixing your lesion somewhere else.
So hemiplegia.
It is hemiplegia only. Okay.
With right UMN facial palsy and Broca's aphasia.
So it's a total hemiplegia on one
yes.
side. Okay. So it's a which area lesion? MCA territory.
MCA territory lesions. Then on arrival in the ER, the patient was.
What you told first is clumsy hand syndrome, monoplegia.
Yes.
There the lesion is entirely different. It is not in the main MCA. Okay, it comes under lacunar infarcts. Okay.
So after coming to the ER, we had taken an initial ECG. ECG was showing a rate of 59 with ST elevations in 2-3 and AVF.
Okay. 2-3 AVF.
2-3 AVF.
Can you get ECG changes in stroke?
Can.
What is the change? What is the common change?
Atrial fibrillation.
Atrial fibrillation can produce stroke. Okay, that's correct.
Bradycardia.
Bradycardia is another problem because of the raised ICV. Then cerebral T wave inversion. Okay, so different types of change, including ST elevation, ST depression, deeply inverted T waves, bradycardia. So many changes can happen because of stroke itself. But atrial fibrillation, like you told, that also can produce stroke. Okay, here it is only bradycardia.
Here it's only bradycardia and ST elevation is also there.
ST elevation in 2-3
2,
AV.
3 and
So
AV.
inferior wall.
Yes.
Okay. What are the complications of inferior wall myocardial infarction?
Hypotension, bradycardia, SA node. If SA node is involved, then
If SA node is involved, then it can produce
bradycardia.
bradycardia, hypotension, shock. Okay. RV infarct also can be associated with it. Is there any RV changes here? Is there any RV infarct in this patient?
They've just they've mentioned only hyperkinesia in the
ECG.
inferior.
You have to check it. RV leads you have to see that any RV changes are there or not. Okay. Because patient is having bradycardia, inferior wall myocardial infarction. There is a high possibility of RV failure. Patient can have hypotension, shock. Okay. The treatment is slightly different from RV failure with shock and LV failure with shock. How do you manage RV failure with shock? So RV failure with shock is fluids are the treatment of choice. Whereas LV failure with shock due to myocardial infarction, it is vasopressors. Like you start noradrenaline, then start dobutamine. Okay, but in RV failure, you have to give fluids first. Okay, so that you should remember. Okay.
CT brain was taken, but initial CT brain was not showing any acute infarct.
So how do you know that this bradycardia is not complete heart block? Is this sinus bradycardia or?
Initially, it was sinus bradycardia initially, sir.
Okay, is there P wave, proper P
P
wave?
wave was there, followed by QRS complex was
Okay,
there.
okay.
So initial CT brain was normal. There was no acute infarct or hemorrhage. So patient was started on alteplase with thrombolysis.
Okay.
60 mg of alteplase was started.
Okay. Will it helpful in myocardial infarction?
Not full dosage.
Dosage is not.
Only thing is dose is different from the like myocardial infarction to stroke, but it will be definitely helpful because some part of the thrombus can be lysed with your thrombolysis itself. Okay.
But then the patient developed further bradycardia going up to a pulse rate of 20.
Okay.
At that time, the ECG showed features of a complete heart block.
Okay. What are the features of complete heart block?
Every P wave is not followed by a QRS complex.
Every P wave is not followed by a QRS
AV
complex.
dissociation AV dissociation
What
is
is
there.
that?
P interval, R interval is equal.
Okay. So P waves come regularly, R wave come regularly, but there is no association between P and QRS complex. How do you differentiate from second degree, high grade second degree heart block to third degree heart block? What are the two types of second degree heart blocks?
Mobitz type 1 and Mobitz type 2.
Mobitz type 1 is?
Progressive prolongation and drop of QRS.
Okay, progressive prolongation of drop of one QRS complex. Second, Mobitz type 2? Okay. Only problem is high grade second degree heart block. High grade, that means every beat will be followed by a block. Okay. In that case, it will be very difficult. Sometimes it will be difficult to make out whether it is a second degree or third degree. But even then, if RR intervals are very much fixed, then you can make a diagnosis of third degree heart block. Whatever it is, high grade second degree heart block and third degree heart block, the treatment is almost similar. Only pacemaking is the treatment.
Patient was started on initially atropine was given, but the bradycardia did not pick up. So then,
what are types of bradycardias atropine will be effective? What are the types it will be effective? What are the okay. If it is a sinus bradycardia, atropine will be definitely helpful. If it is complete heart block, second degree heart block, post cardiac transplant and all, there will not be much change like due to atropine. Okay, so atropine can be given, but it will not work. Okay.
Then patient was put on dopamine infusion, and he was shifted for a temporary pacemaker insertion.
Okay.
Then after the TPA insertion and MRI stroke protocol was taken, and that was showing an acute infarct in the left frontoparietal and occipital region.
By the time you have already done your
Yes.
thrombolysis.
Thrombolysis was
Okay.
done. That's it.
And what happened to the patient afterwards?
So then, at that time, CAG was done, sir. CAG was showing a triple vessel disease
Okay.
with a critical stenosis in the RCA
Okay.
and LAD and LCX also.
Okay.
So patient was intubated during that time, extubated yesterday.
Okay.
So now they plan to do a PTCA.
Okay. So how do you follow up this patient? So this patient is having myocardial infarction, complete heart block. He was treated well. Then here we also have stroke. How do you follow up these patients? What are the drugs will be started on this patient for long-term follow-up?
He should be started on antiplatelets,
What are the antiplatelets you give?
aspirin and
Aspirin?
clopidogrel.
Clopidogrel. Here
Ticagrelol is given.
Okay, then
Statin should be given,
Okay.
atorvastatin.
what are the actions of statins?
HMG.
The main thing is cholesterol, it will
Cholesterol,
reduce
HMG,
definitely.
co-reductase.
But suppose cholesterol are normal, can you avoid statins?
No, really.
No, because it has got an action on plaque, that is plaque stabilization. So it can prevent breakage of the plaque. Okay, then statins can. Which statin you are preferred?
Atorvastatin.
What is the dose of atorvastatin?
80 mg.
80 mg. If it is rosuvastatin,
20.
rosuvastatin acute dose is 40 milligram. Then like atorvastatin you reduce to 40. This has to be reduced to 20. What is the advantage of rosuvastatin over atorvastatin?
PR for rosuvastatin and LFT alternation slightly.
So monitoring is less required in rosuvastatin than atorvastatin. What is the most important side effect of statin?
Myositis.
Myositis. How do they present?
Present with myalgia.
Myalgia, and what is the investigation of choice in that?
Creatine kinase.
Creatine kinase will be highly elevated. Okay, then. So two drugs you have started, antiplatelets and
Statins.
statins. What else you start for this patient?
Can we put on beta blockers?
Beta blockers are good, not a very good choice, because if you are treating complete heart block without any issue, then beta blockers can be started. Otherwise, suppose beta blockers are contraindicated due to bradycardia, complete heart block, what else you can start?
AC.
AC inhibitors should be started within first 24 hours of the myocardial infarction to prevent
Cardiac remodeling.
ventricular remodeling.
Ventricular.
What is ventricular remodeling? What are the drugs used to prevent ventricular remodeling?
ACE inhibitors.
All antihypertensives. AC inhibitors, ARBs definitely. Then beta blockers are not started for ventricular remodeling. It is started for bradycardia, and that in turn produces good effect on ventricle. Ventricular remodeling, the best drug is AC or ARB. Then calcium channel blocker. Third one is spironolactone. So these are three drugs which can prevent ventricular remodeling. Okay, beta blockers are started to reduce the heart rate. Thus, it can reduce the oxygen consumption and demand of the oxygen by ventricles. Then, what other drugs you give? In your ICU, how do you manage this patient? What else you give? What are the other precautions you have to take? Laxative. Most important thing in ICU for any myocardial infarction stroke is prevention of constipation. So laxative should be given. Then what else? So this patient will be in your ICU for at least 2 weeks because he is having stroke. What do you give?
DVT prophylaxis.
DVT. How do you give DVT prophylaxis?
One is TED stockings or starting the patient on anticoagulation.
Will
like
it prevent DVT, TED stockings? It cannot prevent. What are the ideal methods to prevent DVT?
Anticoagulation.
Anticoagulation. What is it?
Parent.
There is no preventive doses you have to try. Anticoagulation is something after something happened, then you are starting. Prophylactic dose to prevent clots. What is the drug?
Parent.
Heparin. What is the dose?
5,000.
5,000?
BD.
BD. Okay, then what else?
Low molecular weight.
Or low molecular weight
Or
heparin. Okay. What else? What else can prevent DVT?
frequent
Frequent
positioning.
mobilization. So leg physiotherapy is very important to prevent DVT. Not touch stocking. Touch stocking will not prevent your physiotherapy. So you have to do physiotherapy, and low molecular weight heparin or heparin can be started. What is the difference between heparin and low molecular weight heparin?
Again, we give monitor the TT, ANR.
Okay, heparin we have to monitor the APTT, not PTNR, APTT. Then
Renal safe.
renal
Safe.
safety is more with
Low molecular. With heparin. With heparin.
heparin. And fractionated heparin can be given in renal failure. Other one we should be very careful because it can increase the dose. So we should try to avoid that drug. Okay. Suppose the patient develops heparin-induced thrombocytopenia. What do you do? It's a very rare complication, but it can happen. Methyl heparin, but we have to give something. No? What else we
Novel
can give?
anticoagulants.
Huh?
Novel.
There is no fondaparinux. Heparin-induced thrombocytopenia occurs. Suppose you have to give heparin, then fondaparinux will be a choice. Otherwise, it is not required. Okay, you can just continue the physiotherapy. Okay. Now, what happened to this patient?
As a patient is planned for a PTCA,
Okay.
probably today or tomorrow within a few days.
Okay.
Patient
What-
was not hemodynamically and stable, so they
Okay.
did not take the patient up for a
How do you
procedure.
manage the diabetes in this patient? How will you manage, if you are the physician, how will you manage this diabetes?
In hospital, patient can be given.
This patient blood sugars are 300 in emergency room. She had stroke, myocardial infarction. How do you manage?
We'll check the HbA1c also.
Okay, we'll check the HbA1c, whether it is uncontrolled for last many days or not. That's okay.
In hospital, we'll put the patient on an insulin,
Which type of insulin?
short-acting insulin.
Okay,
What we give here is human atrapid.
okay,
And based on the GRBS levels, we control the sugar levels.
okay.
And then when we're planning to discharge the patient,
What is sliding scale? What is sliding scale?
Depending on the
Depending upon the blood sugar you are giving, insulin is sliding scale.
Sliding
Is it recommended? It is not recommended. You have to fix the dose first itself. So first 1 or 2 days you can see the blood sugar, and you have to properly fix the dose. And suppose the dose is low, then you can increase the dose. Depending on the blood sugar, if you are giving insulin, then suddenly patient can go to hypoglycemia. So sliding scale is no more useful in ICUs. Okay, it should not be practiced. Then what insulin you will switch to when the patient is getting discharged? What are medications you will give for controlling of sugar in this patient? Dapagliflozin is one choice that can be started if there is a CAD, that along with the other drugs it can also improve the coronary problem. Okay, insulin, will you continue on insulin or not?
we will continue.
It should be continued. What is the advantage of insulin over OHS in chronic diabetes? What is the advantage? Is it advantages or not advantages?
Advantage.
What is the advantage?
Monitoring is easier and it's
Huh? Blood sugar can be controlled with OHA also. But what is the advantage of insulin over OHA in a chronic diabetic patient? The problem of a microvascular disorder will be persisting even after starting the OHS, but it can be controlled only with insulin. Okay, so a patient who already have diabetic nephropathy, induced myocardial infarction, stroke, there is no point in continuing with OHS because they already developed microvascular disorder. To prevent that, you have to continue insulin. So it is always better to start on insulin this patient and continue on insulin. Like dapagliflozin can be added to regime, that's all. But it should not be the only treatment for diabetes. Okay. Anything else? Okay. Thank you.